like a couple of the links have been fixed. So the syllabus is fixed and this class schedule is fixed so far. So hopefully the roadmap will be getting fixed here soon. They are working on it while we're in class. Any questions anyone thought of on break? No? All right, then we will get started on chapter 22. Yes, quick question. We're going to receive the link to sign that says you're here in class. They usually send them out weekly. So you should be getting the one from last week sometime this week, and then the one this week you should get probably at the end of the week or sometime next week. So it'll be sent to the email that you used to sign up for the class. So be on the lookout for those in the near future. All right, chapter 22. So chapter 22 touches on some special care skills. Usually where you would see these sorts of skills would be in more of an acute setting. So if you're working in, for example, assisted living or long-term care, probably not going to see these things. If you're working in a hospital or maybe a skilled care facility, that would be more of an environment where you would be seeing these sorts of things and also assisting residents with these sorts of special tubes and special devices. So residents who are in a subacute setting, usually also called like a step-down unit or sometimes moved to a skilled facility, are residents who require more treatment, more monitoring, and more services than your average everyday long-term care resident. These might be residents who have an illness, some sort of surgical procedure, or some sort of chronic condition like AIDS, cancer, and may require additional care. Residents who require complex wound care, things like mechanical ventilation or dialysis, may also be in some sort of subacute unit receiving additional care. We're going to talk a little bit about surgery. Just to give you an idea, if you do work in a setting like the hospital and you're taking care of residents before and after surgery, what your responsibilities may be. So when someone has surgery, they receive some sort of anesthetic. So anesthesia is a medication that blocks pain during that certain procedure. Reasons that someone might need surgery, there's a lot of them. Typically, it is done to improve structure or function of something. It could be done to remove some sort of tumor, for example, help to relieve symptoms of a disease. Surgery can be done as an exploratory procedure, so diagnosing some sort of condition. Surgery can be done for something like cancer that maybe is going to help to cure that specific type. So lots of different reasons, just kind of depends on what the resident is needing. Types of surgeries. Surgeries can be elective, meaning that they're not urgent, can be done really at any time. So for example, a facelift. They can be urgent, meaning that they need to be done sometime in the near future, but they're not emergent. They're not going to need to be done now. So for example, coronary artery bypass. And then there are emergency surgeries. Emergency surgeries, typically, if they're not done within a certain period of time, like as soon as possible, there can be serious negative effects for the residents, potentially even death. So for example, repairing damage from a gunshot wound. When someone has surgery or a procedure, they may require a different level of anesthesia than someone else who is maybe receiving a more intense surgery or different type of procedure. So anesthesia can be provided locally meaning to just one area of the body. For example, if you are going to have like an ingrown toenail removed, you might receive a local anesthetic directly on the toe. So the toe would be numb and free of pain during the procedure, but the rest of the body would not be under anesthesia. You can also receive what's called regional anesthesia. So for example, something like an epidural for childbirth. So it blocks pain in the lower portion of the body, but still allows for movement and function of the upper parts of the body. And then some surgeries require general anesthesia. So anesthetic is provided to the entire person. So there is no function or movability for that entire person throughout the duration of their surgery. So usually general is used for larger procedures. For example, a hip replacement or a knee replacement may receive a general anesthetic. Knee replacements can also be done with a regional. So it depends on tolerance of the person. It depends on how long the surgery is going to take. It depends on age and a lot of other factors. So determining what anesthesia is going to be used is luckily not our job. It is the job of the doctor. But you may see different residents with different procedures getting different types of anesthesia. So our job typically is taking care of the resident pre-operative, so before their surgery, and then also after surgery or post-operative. So what sorts of things are we going to do before their surgery? We're going to help them get all their questions answered. They usually meet with the doctor, the surgeon, to go over the procedure, to prepare, to ask all of their questions, and also to give consent. Usually the preoperative period is a time of stress, anxiety, worry, fear. So it's a time when we need to be there, be very supportive of the resident, listen to their concerns, and if there's anything that we are unable to answer or address, get that reported to the nurse. Usually during the preoperative period, the resident is NPO. So again, no eating or drinking any food or fluid. The reason for an NPO order before surgery, we kind of talked about this when we were talking about emergency care, is because when someone is going to have surgery and they're going to be put under anesthesia, there can't be anything in their stomach. If there is something in their stomach, that can cause not only nausea and vomiting, but also if they're doing some sort of procedure involving the GI tract, that can prevent their ability to do the procedure. So, for example, a colonoscopy or some sort of abdominal surgery for a disease or condition. We will need to assist the resident with elimination before surgery. There may need to be a special bathing procedure. Oftentimes there's a special preparatory cloth that's used to wipe down the specific part of the body that's going to have surgery. So follow the instructions in the care plan for that. We usually take a set of vital signs, collect any personal belongings that are not going to be needed during that procedure. These could be things like dentures, hearing aids, glasses, hair accessories, bracelets, etc. Depending on the type of anesthetic, if someone needs to be able to communicate, we of course would want to make sure they have things like dentures, hearing aids, and eyeglasses so that they're able to successfully communicate. We'll help them change into a gown, help them get transferred onto the stretcher, make sure that before they leave our care, we have confirmed that they have their ID bracelet on and that it is accurate. And then they go in and they have their surgical procedure. And then when they're done, they come back and we take care of them during what's called the post-operative period. Goals of post-operative care are to promote healing and returning the person to their previous state of functioning, preventing infections, making sure that any complications are identified and reported to the nurse very immediately. Complications can be breathing issues, changes to the mental status, wound healing, pain, infection, variances to the vital signs, blood clots, as well as constipation. So very careful monitoring is important in this stage so that we can identify any of these issues when they first start. To set up a room for someone who is returning from surgery, we usually want to set up the bed to accept a resident coming in on a stretcher. So remember, bed sheets and blankets folded off to one side. We want to get any equipment that might be necessary, clean sheets, bed protector, towels and washcloths, an IV pole, equipment to check vital signs, emesis basin, oxygen equipment if they need it, warm blankets, pillows, or other positioning devices might be necessary. When the resident comes in on the stretcher, we want to assist them to transfer from the stretcher back into bed, return all of their personal belongings, follow the care plan for how frequently to measure vital signs, as well as reposition. We might be assisting with deep breathing exercises. We may be elevating extremities if they've had a knee replacement, for example. We may be assisting with the application of compression socks or TED hose. They may also have what's called a sequential compression device ordered. A sequential compression device is almost like a giant blood pressure cuff that goes on the legs, and it helps with the circulation. So I'll show you what they look like. Usually you would only see these in like a hospital type environment. So if you're in like a skilled facility, probably not going to see them. But they're used to help prevent post-operative blood clots. So they look something like this, maybe. Where'd you go? Picture. Maybe not. We'll try this one. There we go. That picture shows up. So they look something like this. So they look like a giant blood pressure cuff on the legs. And what they do is they connect to a little machine, and that little machine inflates them, so to compress the leg, and then deflates them. So it allows for that venous circulation to return back up to the heart. So it's helping to promote circulation and hopefully prevent blood clots. In more of a long-term care or maybe skilled facility, usually you would see something more like TED hose or compression socks for that purpose. We would want to know what sort of surgical incision these residents have, if they have any drains, where those drains are, what the drainage that's coming out looks like. We want to assist them with bathing, grooming, elimination. If they have orders for ambulation or range of motion exercises. We also want to make sure to follow their dietary orders. So typically after surgery, people progress through a clear liquid diet, a full liquid diet, before they get back to eating regular solid food. So follow those diet orders in the care plan. Things that you want to report immediately to the nurse postoperatively: any change in vital signs, changes to the mental status, if they're disoriented or confused, breathing changes, if they are not easily arousable, their level of consciousness decreases, they have a cyanotic appearance to their skin or the skin becomes cold and clammy, if the drainage from their tube is increasing, if they have any swelling, pain, tenderness, numbness or tingling, if they're nauseous or vomiting. Some people get nauseous and will vomit after they have anesthesia. So if that's the case, make sure it gets reported. Also, if there's any issue with any of the equipment that they are hooked up to, like the sequential compression devices, the IV, the oxygen, what have you, make sure that you would report that to the nurse. Any questions about pre or post-operative care? All right. So the pulse oximeter, we already talked about, right? That's this thing. This one is portable. In an acute care environment or subacute environment, usually you're going to see something more like this. Let me pull up a picture. And I think I mentioned it before, but they're more of a permanent fixture. So they are usually attached to the residents. They don't come off, and they are constantly monitoring their oxygen. They're usually attached with an adhesive. They usually look something like this. So this little, let's see, there we go. Tan colored portion of that is wrapped around the finger. So it has the light going through that little device, and then it plugs into the machine that is able to keep a constant reading on it. So for an acute care setting, we're using this constantly around the clock. We're not just coming in and checking the oxygen level when we do vital signs. So it gives us a better idea, a quicker notification if something is going wrong. So that's what you would usually see in more of an acute care setting versus just long-term care. So again, optimal range for pulse oximetry, usually above 95%. 100% is the max. You can't go over 100% oxygenation. If there was any decrease or the monitor was alarming, we would want to report that to the nurse. In general, if that pulse oximeter is stuck onto the finger, we're going to check for skin irritation. We're also going to let the nurse know if it falls off, the resident takes it off, if it's not sticking properly. We would want to make sure to note when a resident is receiving pulse oximetry and oxygen, if the oxygen comes off, noting that the pulse oximetry is probably going to reflect that reading. So if someone is on oxygen and they take that oxygen off, or the oxygen stops working or what have you, their pulse oximeter reading is going to reflect that. So if you have a low reading below 95, check to make sure that their oxygen is on, make sure it's actually physically on their person, make sure they haven't just taken it off and tossed it off to the side, and then of course report that to the nurse. Telemetry, also called tele, is a special cardiac monitoring device, and it keeps a constant eye on the rhythm and the rate of the heart. So instead of just applying a blood pressure cuff, checking the blood pressure, and reporting that to the nurse, this device actually monitors the heart's rhythm as it is beating. The device takes that information and sends it to a monitoring station where people are constantly looking at everyone's heart rate and rhythm. So if there is something wrong with that heart rate or rhythm, then the nurse or doctor is notified of that. So it's not something that we are watching, but it is something that is being monitored, usually in a central location, for any issues. So if we're taking care of someone who is under telemetry, we are going to see that they are attached to some little pads that are then attached to wires attached to a machine. So what that looks like is this, maybe. Here we go. So this is a pretty simple one. Usually they're hooked up around the chest, on the arms, and also on the legs. So these little wires hook up to the machine, the pads that go on the resident attach to the wires, and then provide that monitoring information. So usually the pads are just like white and blue. They look something like this. and they stick onto the skin. So there's an adhesive that sticks them onto the skin, and that allows for that signal to be transmitted. So if when you're taking care of someone who is on telemetry, that little sticky pad comes off, if there's irritation on the skin around the sticky pad, if the cardiac monitor is alarming, if the resident reports any cardiovascular respiratory symptoms like chest pain, breathing difficulty, or if there are any changes to vital signs, we would want to report those things to the nurse immediately. Any questions about oxygen or tele? All right. Moving on then to artificial airways. So artificial airways are basically when a tube is inserted into the resident's respiratory tract to allow for them to breathe. The process of inserting an artificial airway, which is only done by doctors or specially trained nurses or respiratory therapists, is called intubation. So intubation is where the tube is inserted either through the mouth, nose, or the trachea directly to allow for that airway to be patent or to be open. When we have something inserted into the trachea, the procedure itself is actually called a tracheostomy. So a surgeon creates an opening in the neck to go directly into the trachea. That might be necessary if there's some sort of obstruction or some sort of injury to the mouth or the nose. May require bypassing those structures and going directly into the trachea. So if someone is utilizing an artificial airway, please note that they usually cannot speak. We need to find some other way of communication. This is a time of heightened anxiety for that person. Watch for anxiety, biting or tugging at the tube. Be very supportive and reassuring. Know that even if this person cannot verbally communicate with you, they can still hear you. So always introduce yourself, explain what you're doing. With an artificial airway, we need to provide oral care often, even though they're not eating or drinking. We want to report any changes to the vital signs to the nurse immediately. So again, tracheostomies, here's a couple of reasons why they might be necessary. If we can access the airway through the mouth or the nose, those are the preferred routes because they don't require a surgical incision. But if somebody has some sort of obstruction, injury, some sort of reason why we can't get through the nose or mouth to put in a tube, then the tracheostomy, that surgical incision in the neck, may be necessary. As far as a tracheostomy goes, unless someone has had a tracheostomy for an extended period of time, they usually cannot verbally communicate. We need to find some way to communicate with them that is successful for them. We need to make sure that we are responsive to their needs, so answering their call lights promptly. We also want to make sure that even though we're not doing anything related to the tracheostomy, because all of that care would be sterile, that we are observing and reporting to the nurse if we notice any issues or changes. So issues or changes might include difficulty with breathing, maybe discharge from the trach, some sort of phlegm or sputum being coughed up, any sign of skin breakdown around the tube, discomfort or if the tubing comes out or becomes disconnected. Another telltale sign of respiratory secretions collecting, which can make breathing difficult, is a gurgling sound. So if you hear a gurgling sound when they're breathing, you would want to report that to the nurse. That will typically require the nurse to do what's called suctioning to be able to clear out those secretions and prevent aspiration into the lungs. Remember, when you're caring for someone who has a tube that is inserted into their body, they are at a higher risk for infection, right? Because infection can get in that tube or around that tube. So something like a tracheostomy or a chest tube, a catheter we already talked about, an IV line. We need to be very careful following those infection prevention measures that we talked about last week. I want to show you what a tracheostomy looks like. It's also abbreviated as a trach. If you hear that, it's the same thing. So a trach looks like this. There we go. That's a little picture, but see if we can make it bigger. There we go. Aha! So the trach itself goes through the front of the neck. So an opening is created surgically, and that tube goes directly into the trachea. That tube stays in place one of two ways. Some trachs have a little balloon that is blown up to keep them in place, kind of like how the catheter is held in place. Some of them are sutured, so they're actually stitched to the skin around them. So if your resident has one of these devices, important to know that it is there. Also important, again, to observe and report on anything that you notice with this resident's trach. Moving on to mechanical ventilation. So mechanical ventilation goes a step beyond something like a breathing tube. So a mechanical ventilator is is a machine that is connected to the breathing tube. The mechanical ventilator actually does the job of the lungs in the event that someone is unable to use their lungs to take breaths in and to release breaths out. So the mechanical ventilator inflates the lungs and deflates the lungs. When someone is receiving mechanical ventilation, they're typically on what's called a sedative. A sedative is a medication that helps to keep them calm. It usually causes pretty excessive sleepiness. So a lot of times your residents will appear to be fatigued or sleepy as they are receiving mechanical ventilation. If they were not on a sedative and there was a machine inflating and deflating their lungs, the chances of them having heightened anxiety and trying to pull out their breathing tube would be very high. So it is to keep them safe and to allow for the mechanical ventilator to do the job that the lungs are not able to do. So a mechanical ventilator depends on the setting you're in, but typically it is a big machine. That big machine has lots of different settings that are adjusted not by us, but by the doctor, respiratory therapist, or nurse. And the mechanical ventilator inflates the lungs and then deflates the lungs. So it puts air in and then takes air out. So here's an example. You can see the resident, their lungs, breathing tube. Attached to that breathing tube is another tube which connects to the mechanical ventilator. So there's a way for air to go in, and then there is a way for that air that comes out to be discarded. Of course, as the nursing assistant, we would never adjust any settings on a mechanical ventilator. Our job is pretty similar to everything else we've talked about in this chapter, which is to observe and to report to the nurse if there are any issues. So you might be thinking, why would someone need a machine to breathe for them? Well, if their lungs are not working properly, they've had some sort of respiratory or cardiac arrest, they have a lung disease or an injury to their lungs, or they've had a head or spinal cord injury which has affected their respiratory control center in their brain, they may need this additional support. Again, residents on a mechanical ventilator are going to be sedated. They're not going to be able to speak. Being on a ventilator, so someone who has been on a ventilator before and then recovered and come off that ventilator has actually compared that to breathing through a straw. So imagine if you got a straw out of your kitchen, put it in your mouth, and you breathed in and out through that thing all day long. Yikes, right? That's going to cause some anxiety. Even though we can breathe, breathing through a straw is going to cause some anxiety. Always make sure when you're taking care of someone who's on mechanical ventilation that you enter the room so that they have the ability to see you. Make sure that even though they may appear sedated and they're not communicating verbally, that you introduce yourself. Also, make sure that you always explain what you are doing, just like you would to a resident who was engaging with you and able to verbally communicate. There was a story a while back, more towards the earlier years of COVID, and there was a gentleman who had been on a mechanical ventilator with COVID who had recovered, and he came back to the hospital where he was receiving his treatment, and he thanked one of the nurses because she always, when she entered the room, she introduced herself, and she always told him what she was going to be doing, and he remembered hearing her. Isn't that crazy? So that goes to show, even if they don't act like they can hear you, they can still hear you. And it's still just as important to make sure that we are going through that verbal communication, updating them, even though they're not responding. So guidelines for caring for someone on mechanical ventilation. Of course, if there's any issue with the machine, it's beeping. Any issue with the tubing, disconnected, comes out, we would want to report that to the nurse. Giving careful skincare is really important, monitoring for any skin breakdown from that tubing. Repositioning the resident. Usually if they're on mechanical ventilation, there's going to be an instruction in their care plan for how the head of the bed needs to be maintained. So repositioning them with the head of the bed maintained at that specific indication from their care plan is important. We don't want to lie them completely flat for any reason unless we have the okay to do so. Again, if the resident is showing any signs of anxiety, biting, pulling at the tube, we want to report that to the nurse. And we want to be sure that overall we're being supportive, being positive, and of course, communicating. Any questions about mechanical ventilation? If you've never seen someone on a mechanical ventilator, it's interesting to watch their respirations because you can see when the machine pumps the air into the lungs and then when the machine takes the air out of the lungs. So it is a lot different than our typical breathing where, you know, we can breathe in and out and you can't always necessarily see that. But the mechanical ventilator, the way that it pushes the air into the lungs and then the air comes back out of the lungs, it's kind of similar to maybe giving a breath with CPR, how you can really watch the chest rise and fall. So if you're ever taking care of someone who's on mechanical ventilation, pay attention to that. Moving on to suctioning. So I mentioned suctioning when we were talking about trachs. So when someone is collecting secretions in their respiratory system and they cannot clear them out on their own. So typically you and I, if we have something collecting in our respiratory system, we just cough or clear our throat, right? And that gets rid of it. If someone cannot do that on their own, they may require suctioning to remove those secretions so that the secretions don't build up and become aspirated into the lungs or cause infection. So suctioning, typically you will have either a portable suction device or suction that's actually directly hooked up to the wall. So that would be more in a hospital setting. A portable suction device looks like this. It typically requires a power source, so it needs to be plugged in. It has a little canister. The little canister collects all of the secretions, and then it has a tube that is used by the nurse to stick into the respiratory tract and to remove secretions. So this doesn't want to load really well, but you can kind of see the picture. So that is a portable suction device. Again, if you're in the hospital, it usually just hooks directly up to the wall. If someone needs suctioning, the indications, the symptoms that they would have that you would report to the nurse that would initiate suctioning: gurgling, like we already talked about, breathing difficulty or an elevated respiratory rate, if they have a pale or cyanotic appearance to their skin, if their nostrils are flaring. So if they're breathing and their nostrils are flaring out, that's a sign that they're not adequately breathing. If their chest is retracting, and what that means is if their chest is sinking down below the normal level each time that they breathe, like they're trying to gasp, that is an indication of respiratory distress. Also sweating and coughing or wheezing, trying to cough up secretions that aren't able to come all the way up is a good indication that they may need some suctioning. I saw a question. There is a suction device for the nose as well. So there's different ones, like for babies, they use the little bulbous syringes. You can use a suction device in the nose as well. You just have to receive proper training depending on how far back in the nose and also how far back in the mouth you're going for suctioning. So there are different attachments for the suction device that can be used for different things. So noses, mouths, deep throat suctioning is something that can be done as well. Good question. So after you report any of those signs of distress to the nurse, what's going to happen is the nurse is going to probably request your assistance with the suctioning procedure. Usually what the nurse is needing help with is, after they perform the suctioning, having you perform oral care, maybe clean their face, maybe wash it with a washcloth. Usually for suctioning, if the suctioning is occurring in the nose or the mouth, it's not typically a sterile procedure, just a clean procedure. If the suctioning is happening in the tracheostomy, it is a sterile procedure. So be very careful if you're helping the nurse with a sterile procedure not to touch anything unless you're instructed to do so. Moving on to chest tubes. Chest tubes can be inserted into the chest typically during surgery. They can be done at the bedside if there's an emergency. And the reason that someone would need a chest tube is if they have something in what's called their pleural cavity that is pressing on their lung and preventing their lung from being able to fully expand. So that something could be air, it could be an infection, maybe purulent or pus drainage, it could be blood. So kind of depends on if there was an injury, if there's some sort of illness, for what that sort of thing that is needing to be drained will be. So with a chest tube, the chest tube itself drains out whatever air, blood, what have you, into a special device, which is called a chest tube drainage system. This chest tube drainage system is a closed system, so there is no air that can get into that system. Really important that that device is airtight, because if it is not, then whatever has gotten into that pleural cavity to fill it up and prevent the lungs from expanding is going to be able to get right back in there. So knowing how to use the suction device is very important. Making sure that it is always in an upright position, doesn't get knocked over, kicked. Also, I'll show you what one looks like, but it's kind of hard to mimic what happens if air gets in the system. So if you ever do see one, pay attention to the device and how in the device there's a little bit of bubbling that occurs. That bubbling makes sure to tell you if there's an air leak or not. So it's a very complex device, but very simple to use in that basically we're looking for bubbling or no bubbling. So that suction machine looks like this. maybe. Where'd it go? There we go. So this little device, it's got a lot of complex measurements on it. We don't need to know any of that. What we need to know is it is connected to the patient's chest tube. It monitors the amount of drainage. It also lets us see the color, so the characteristics of the drainage. It has a little dial that can provide suction, so the doctor will adjust that. It also has an air leak monitor, so that's where I was saying if you're noting that there is bubbling in there, that can be an indication that there's some sort of leak in the system. So that little blue area over on the left bottom there. So for our purposes, what we are looking for is any abnormality in this system or any issue with the chest tube, and then we're reporting that to the nurse. We're not actually doing anything with the chest tube. So all of that information, all of those precautions or what to report will be noted in the care plan as well. Most importantly, when someone has a chest tube, please know where the chest tube is. That way we don't kink the chest tube when we're repositioning the resident. Also know that if the resident is hooked up to that chest tube drainage or suction system, same thing with the catheter and the IV, that needs to be kept below the level of the chest tube, because if it's not, gravity is going to take whatever we've drained off the lungs and put it right back in, which is not the purpose. Make sure that if there's any issues with the chest tube or the equipment, that gets reported. Usually someone who is on a chest tube suction system, we are monitoring INOs, and output does include anything that is being drained into that system. So when you are calculating your INOs, looking to see how much drainage has come out, looking at that chest tube drainage collection device and taking note of that. These residents may be doing deep breathing exercises. They typically need frequent rest periods. Imagine if one of your lungs was not able to inflate properly, you wouldn't be able to breathe well. Therefore, you wouldn't have a lot of exertion to be able to exert. We already talked about feeding tubes. We talked about IVs. Those residents require more care than our typical long-term care resident, but those sorts of things can be managed in more of a skilled facility or long-term care facility as well. Any questions on any of those special care topics? No? All right. Then we will move on. So our next chapter is chapter 23. Chapter 3 is on death, dying, and hospice. One thing I want you to know about this chapter, about hospice care in general, is it's not for everyone. Same thing goes for a lot of the chapters we've talked about. For example, caring for someone with dementia or Alzheimer's, it's not for everyone. Caring for maybe the older population, caring for pediatrics. Some of these things are just something that maybe we don't have that desire to do, and that's okay. Know for yourself if, I talk about dementia and Alzheimer's and you start to cringe, maybe that's not the best place for you to work, if that's not something that interests you. We all have different passions, and that's really the beauty of healthcare, is there's so many different things you can do, so many different people, populations, disease processes that you can work with. So if you're like, the hospice, I don't want anything to do with hospice, that's okay. It doesn't have to be your first choice. It is important to learn about it and to know about it. But like I said, there are certain things that maybe don't sound appealing to each of us. I know sometimes it's hard to say those things like, oh gosh, I don't want anything to do with someone who's on hospice, or I don't want to do anything with someone who has Alzheimer's. For me specifically, it's pediatrics. I don't want anything to do with sick children, nothing at all. So if I was applying for jobs as a nursing assistant, I would avoid anywhere that took care of children under the age of 18. That would not be for me. So if you have something like that, know that it's okay. We all have that. And know that you probably don't want to apply at a facility that you're going to be taking care of that sort of person or that sort of disease process. So hospice care, when we talk about the dying process, usually when someone is put onto hospice care, they have what's called a terminal illness. So a terminal illness is a disease or condition that is going to cause death. When we talk about the process of death, it's a process not only for the individual or the resident experiencing it, it's also a process for their family members, for their friends, and their loved ones. So when we look at the stages of dying, typically when someone receives a terminal diagnosis, they start to go through some of these stages. Not everyone goes through each stage, and not everyone goes through them in this order. So it depends on the individual. So it usually starts with denial, denying the fact that they have a terminal illness, then progresses maybe to some anger, like, why do I have this illness? Then maybe some bargaining, like, okay, but maybe some depression, maybe needing to review positive times, positive experiences. This is a stage where people like to tell a lot of stories. And then acceptance. And again, not everyone goes through every stage. So some people don't accept the fact and don't prepare themselves for that death. Some people do. Some people prepare themselves and their families before they actually die. Reactions from family, friends, and loved ones to the death of their resident. Sometimes it's shock, sometimes denial, sometimes anger, maybe at whoever diagnosed the terminal illness, maybe at the person who died for whatever caused the terminal illness, maybe guilt, maybe regret, maybe a sense of relief. Like maybe this person's been suffering for an extended period of time, and the fact that they have died is now a relief that they're no longer suffering. Maybe some sadness, depression. A lot of times, family members have difficulty sleeping, have headaches, as well as loneliness. So, going through all of their memories with that loved one and trying to, piece together the fact that those memories are in the past and that they no longer have access to make new memories with that loved one. So, how do we determine someone's response to death? There's a lot of factors that go into play here. So, experiences with death in the past, personality, any religious beliefs, as well as cultural background. So, each person's experiences, each person's ideas and background regarding death are going to be a little different. So, think about your own experiences or your own cultural or religious influence or beliefs, and what your feelings are about death, how you would approach death, or maybe practices that you know of after death that you think would be familiar or would be common practice. Know that your experiences are not wrong. Know that other people's experiences may be different. So, people's ideas, people's response to death is very different. A lot of times with family and friends, that experience when they're there and their loved one has died, that experience a lot of times is shown very emotionally, crying, being depressed, sad, having all of those feelings. Some people don't have that response at all. And that is not abnormal. Any feeling following death is normal. I've seen family members who are, sitting there silently with a straight face. I've seen family members who are hysterical. I've seen family members who don't even want to be present. They don't want to be there. They want someone to call them and let them know. And that's their way of dealing with that. That's their response to the situation. So again, really important that we're non-judgmental of how someone responds to that death. I also want you to know that when you're taking care of a resident who is dying, once that resident dies, and also while you're taking care of them throughout their last days and hours, you're also taking care of their friends, family, and loved ones. A lot of times people want to be there with their loved one. So you might have friends and family at the bedside. Once that resident dies, our goal and our focus is to take care of the resident and their body, but it's also going to be to focus our attention on their loved ones, to help to comfort them, to help them to understand the process, the next steps, what's going to happen. So caring for someone who's dying is more than just caring for that resident. It's also caring for their support system. So please keep that in mind. When you're caring for someone who's dying, know that their body systems are starting to shut down. Senses diminish, vision, response to the outside world diminishes. Our focuses are really on making sure to care for their skin, to ensure that their pain is well controlled, to make sure that their environment is comfortable, and to provide them with support. Also, please note that if someone has an advance directive, that advance directive has to be followed regardless of what our own personal feelings are. We cannot make decisions for someone that go against their advance directive. So if they have an advance directive, we follow the advance directive during this process. If they don't have an advance directive, typically your facility will tell you that they are considered to be a full code, like they would be a full intervention if they were to have cardiac or respiratory arrest. Usually, when we talk about someone who's dying and receiving hospice services, usually hospice is going to require some form of an advance directive. And also there's a discussion when someone goes on to hospice about that person being a DNR. So ultimately, we're not trying to cure them or save them. They have a terminal illness and they're going to carry out the process of death. So remember those resident rights that we talked about? Keep in mind that even though someone is approaching death, they still have rights. They still have the right to refuse any treatment. They have the right to privacy. They also have the right to have visitors of their own choosing. And I want you to know that people don't die during normal business hours. They don't die between the hours of 9 to 5 when we would typically accept visitors. People die all hours of the day. Someone who's dying typically has visitors, friends, family, all hours of the day. So they may have someone who stays overnight with them if your facility allows that. They may have someone who gets there early in the morning and stays at their bedside until late at night. So you need to know that those visitors, they're not always just there during visiting hours. They may be there overnight, they may be there early hours, late hours, etc. As far as the right to refuse treatments, this one can be hard. Whether you agree or disagree with their refusal, remember that the choice is theirs. Sometimes if residents aren't capable of making decisions, remember they have designated someone to be their durable power of attorney for healthcare decisions. We need to assume that that durable power of attorney for healthcare decisions is following the resident's wishes, and we would never go against or tell them that we disagree with how they are handling that situation. So think about if you've ever taken care of someone who didn't want to receive any more treatment for their diagnosis. Think about how that made you feel. So maybe you're taking care of a resident for, I don't know, 5 or 6 years, 10 years, you're taking care of them. Maybe they get a terminal diagnosis of cancer. Maybe they try out, some chemotherapy and they're like, yeah, I don't want to do this anymore. I don't like this. It's not helping me. Makes me feel terrible. I would rather just, proceed with the course of cancer and ultimately die. How are you going to feel about that? That's your favorite resident. That's someone you've taken care of for a long time. And now they're refusing treatment. So just think about that. I want you to think about these things before they actually happen. If you don't, they're really hard to face when they do happen. As far as the right to have visitors, visitors are a very important part of the dying process. Saying goodbye to a loved one or a family member can be really important for dealing with that death. It's also very reassuring for people who are dying to have someone present with them in the room, even if it doesn't seem like they're aware of their surroundings. So actually, we're going to talk about the dying person's Bill of Rights. They actually have the right to not die alone. They have the right to have someone there present with them. So here are all of those rights. You can see the fourth one up from the bottom is the right to not die alone. They have the right to be treated as a human being. They have the right to be cared for by people who have a sense of fulfillment for the work that they do. People that understand that they're not there to cure their illness or sickness. Instead, they're there to be comfortable. They have the right to be free from pain, to not be deceived. So we would never want to try and deceive someone and tell them, like, oh, yeah, you're going to get better. No. If they have a terminal illness and they are dying, they're maybe on hospice care, we would not tell them something to give them that false sense of hope. They have the right to die in peace and dignity, to not be judged for decisions that they make, regardless of whether other people have the same beliefs as them. They have the right to discuss their religious or spiritual preferences and experiences. The right to expect that after they die, their body will continue to be respected by those that are caring for them. They also have the right to be cared for by sensitive and knowledgeable people who are going to attempt to understand their needs and are going to help them to face their death. So, a couple of additional rights in addition to the regular resident rights that we talked about. So like I said, the right to not die alone, that one's really important. So there are a lot of studies on this. Like I said, people who don't necessarily interact with us verbally or maybe have any awareness of their surroundings can still hear us, right? They can still sense our presence. So there's been a lot of studies on the dying process and whether or not someone can really tell if they're alone when they're dying. And the research indicates that yes, usually that person has enough awareness that maybe we may not recognize to know if they're by themselves or if they have someone there with them. I'll give you an example. Interpret it however you would like, but in my own personal experience, that lovely little lady that used to walk down the hall and perseverate on whatever she heard last, the one that we would say, I love you, and she would just say, I love you, I love you, I love you. When she was dying, she had a son that lived in town, and she had a son that lived out of town. The son that lived in town visited her frequently, regularly. Son that was out of town didn't come very often. When she was in the process of actively dying, that son got on a plane and he was making his way here. And so her son that lived in town told her, your other son, we'll call him Jerry and Larry. So let's say Jerry lives here and Larry lived far away. So Jerry told her, Larry's coming. He's getting on a plane. He wants to come and see you. So she's actively dying, meaning she has signs that she's approaching death. And she made it through the night. Jerry stayed with her until Larry arrived. So Jerry left, and it was after I had worked a night shift. Jerry left. I stayed there. Jerry went and picked up Larry from the airport, brought Larry back, and Larry walked in, and he said, Hi, Mom. It's Larry. I'm here. I just wanted to say goodbye. I kid you not, she took her last breath, and she died. So my thought on that is, she knew she was waiting for Larry. Larry wanted to say goodbye. Larry came in and said his goodbye, and away she went. Like I said, take that however you want to interpret it. But for me, that was kind of proof that, like, okay, that there is actually some sense of there's people here or there's not people here. So interesting. Look up the research if you are not familiar with that. When I worked in the geri psych facility, we kept residents once they went on hospice. We didn't send them off to a different facility. So we would take care of them until they died and after. And we would have residents that had moved in when our building was new. There was actually a couple residents that I had previously taken care of in their homes that moved into our facility. So I'd known them for years. And when they would progress to hospice care, I would volunteer to just stay with them. And if they didn't have family or friends present, I would stay overnight. I was in nursing school, so I used that time to study. So double whammy, right? Hang out with someone, provide your presence, get some studying done for your exam that you have the next day. So I took that opportunity, especially for people that didn't have family or friends. We had one little lady, and I took care of her in her home. When she was unable to care for herself, she ended up moving into that facility. She didn't have any friends or family. She had a guardian ad litem, which means a court-appointed person to make her decisions and to basically be notified of when she died. So she didn't have any support. She didn't have anyone there. Nobody came to visit her. When she was dying, all of us volunteered. We signed up for volunteer shifts just to sit with her. That way she wasn't alone while she was dying, because we knew nobody was going to come in and sit with her. It was basically us. And ultimately at that point, we were her family, right? She had been living in our facility. We'd been taking care of her. She's been interacting with us day in and day out. And so we were the ones that sat with her while she died. If somebody does have family or friends present, really important to take care of them as well. If they're there, offering them a pillow, a blanket, if they want to stay overnight, what sorts of accommodations can we make? Offering them a glass of water, a meal. If they're there for lunch, you could just say, hey, we're serving lunch. Are you interested? So trying to take care of not only their loved one, but also incorporate them into that caring as well. For the person who is dying, we want to make sure that we're engaging them with any activities, meal times, as long as they want to. If they start to refuse meals or refuse activities, they don't want to get out of bed, that's their choice, and we should honor those choices. Also, please note, when someone is dying and they have family members or friends visiting, do not avoid that resident just because they have visitors. You still want to do the same care, the same checks that you would be doing if their family was not there. So always knock on the door. When you get permission to go in, just let them know, hey, I'm here to provide some personal care to your mom. Usually they're like, oh, okay, great, I'll step out. Or you can pull the curtain and they can just kind of wait for that care to be provided. So never avoid someone just because they have visitors. If you avoid them, their family is probably going to wonder why you're not there providing care. So please still continue to provide them with that care. Any questions so far? All right. So moving on to what the actual definition of hospice care is, and also something similar, which is called palliative care. So hospice care is holistic, meaning we are caring for not only the physical aspects of the person, but also the emotional aspects. Compassionate care that is given to someone who has a terminal diagnosis that is going to live for approximately 6 months or less. Just because someone is put onto hospice care does not mean that they're going to die within 6 months. Some people go onto hospice care and come off of hospice care. Maybe their condition improves. Some people go on to hospice care and remain on hospice care for longer than 6 months before they die. So that 6 months is an approximation. It's not a definite. Palliative care is a little bit different. in that someone may not have 6 months or less to live, but they have some sort of terminal condition, and they are no longer wanting to be cured of that condition. Instead, they're wanting to be kept comfortable. So they want to maintain their dignity, they want to be comfortable, and they want to live out the rest of their life. So I'll give you an example. My grandpa has congestive heart failure. He's had like 37 heart attacks in his lifetime, 2 in the last 3 years that were pretty big. And he's in his 80s. He's older. He's lived a great life. He's not necessarily going to die within the next 6 months, but also medications that he's receiving are not going to be curing him. At this point, he's had so many heart attacks that the majority of the heart muscle itself is dead. So his cardiac functioning, it's a percentage that they go by, and his is below 25%. So ours probably 100%. His doesn't function well. So it's not circulating well. It's not removing waste products well. It's accumulating fluid. So instead of trying to make that better, trying to get rid of that and improve the function, he's on palliative care. So what he does is what makes him comfortable and what makes him happy for however duration of life he's going to live. So what the doctor explained to him was he may have another good 5 years, but if he has another heart attack, he may only have another good few months after that. It kind of depends on where the heart attack occurs, what part of the heart is damaged, how much cardiac functioning he has. So instead of live in that constant fear of the next heart attack, he's comfortable. So for his birthday, he wanted a Big Mac. He's supposed to be on a sodium restriction for his heart and also a fluid restriction. But now that he's on palliative care, he wants to be happy and comfortable. So he was comfortable enough to eat a Big Mac, and he was happy when he ate the Big Mac. So that's what he's doing. So palliative care puts the focus more on promoting whatever remainder of life someone has as being happy, positive, and comfortable. So there's not that 6 months or less to live, but there is a condition that is ultimately, at some point, going to result in death. So as far as what to do when you're caring for someone who is on hospice care, like I said, a lot of times they want to go through all of their good memories. Maybe they want to provide you with some advice or tell you about some stories that happened. Be a good listener. Listen to understand. Try to promote independence for as long as we can. Be sensitive to each individual's needs. Remember, not every person goes through all of those different stages of grief. Be aware of your own feelings. Recognize that it is stressful to take care of people who are dying. Again, taking good care of yourself, eating nutritious foods, drinking water, getting adequate sleep, exercise, taking your breaks, all very important to allow you to adequately take care of other people. It's really important when you're working in this sort of environment to find a productive way to deal with your own feelings. So again, we talked about what you do to help decrease stress. Think about those things. Think about what helps to promote relaxation for you. Make sure that you take some time to do those things that are going to help you to deal with the type of work you're doing. Any questions so far? All right, then we'll go ahead and take our second break. I need more water and a snack, so we can take 15 minutes and then we'll come back and keep going on chapter 23. Go ahead and turn off your microphone and your camera. I'll see you back in 15.